Okay, we'll get started. I would like to welcome everybody today. I am Sharice Magoon and I work at UT Health San Antonio School of Nursing. I'm going to be moderating the session today. Earlier this morning, you were sent an email from Cynthia Gutierrez, and at the bottom of the email, it explained how to complete your evaluation of the course today and how to get your certificate. So if you have any questions regarding that process, Cindy's going to type her email in the chat, and then you can reach out to her after the session's over and she can help you with that. This symposium is sponsored by Texas Health and Human Services Commission in partnership with UT Health San Antonio School of Nursing. Texas recognizes June as Neonatal Abstinence Syndrome Awareness Month. You can learn more by reading House Bill 405. During the presentation, if you'll please keep your camera and microphones off. If you do have a question during the presentation, we would like for you to go ahead and either type it in the chat or go ahead and unmic and ask it at that time, and Ms. Cisneros will address it. If not, you're more than welcome to hold your questions and your comments till the end, and we'll get to those. And also, just so you know, we're recording the session. Today, our presenter is Tina Cisneros, LPC PSS, Peer Specialist Supervisor. She has worked with the Center for Healthcare Services for 13 years and is currently the interim clinical director for the Community and Crisis Response Service at Haven for Hope. Throughout her tenure, Tina gained a strong crisis background through her experience in residential settings as a case manager and onto a supervisor focused on targeting homelessness, substance use, mental health, and the NAS population. Tina has spent the past year at NAS residential program utilizing her PSS license as a clinical administrator. And without further ado, I will hand it over to you, Tina.
Thank you. Good afternoon. My name is Tina Cisneros. I am, like Sharice had mentioned, the interim clinical director here at Haven for Hope. I did serve as the clinic administrator at the Neonatal Abstinence Syndrome residential program. So today I'll be presenting on 2 different programs in the same location within the NAS residential program. Our first program, or the 2 programs I'll be speaking on, is the NAS PPW, which is the Pregnant and Parenting Women residential program, and the NAS RRH program, which is the NAS Recovery Residence Home program. So these particular programs are located in the same location. We do have a we do have this particular residence. It's a home-like setting located at the northwest side of San Antonio. So let me go ahead and start. So for the Neonatal Abstinence Syndrome residential program, we're serving San Antonio community since 2016 as the only pilot program specializing in opioid substance use disorder for women. As I mentioned, we're sharing a facility. So the NAS PPW program has 11 beds dedicated to that particular program, and 3 beds dedicated to the RRH program with a total of 14 beds on site. The admissions to both programs are conducted Monday through Friday, 8 a.m. to 2 p.m. For the NAS Recovery House program, this particular program is a recent addition to the unit. As I mentioned, it's a 3-bed unit extension program offering pregnant women and parenting women completing or co-enrollment in treatment for opioid use disorder who otherwise lacks safe and stable housing. The core services include an applicable medical, clinical, and recovery support services. This program ensures a safe and affordable drug-free living situation for women and infants. So in the RRH program, this particular side of the house is separated. So the back part of the house, we have a room with 3 beds. In this particular program, women and children are welcomed. We do welcome children under the age of 3. So the criteria for this particular program is parenting or a pregnant woman who is diagnosed with the opioid use disorder, moderate or severe. It's not as intensive in this particular program. Usually what I've seen is the more intensive program, the NAS PPW graduates will usually transition over to NAS RRH as maybe a step down prior to reintegrating into the community. Our NAS PPW program is more intensive group services, individual services, counseling. NAS RRH is mostly geared towards peer services. So we provide that service to these particular ladies. We do have a recovery coach on site that checks in with the ladies once a week. So the ladies are required to at least do 20 hours of groups, to attend 20 hours of groups within the week. Every week, they're required to check in with the recovery coach who provides the peer service. Our recovery coach is a certified coach. And I believe the certification is the RSPS, which is a recovery support peer specialist. This individual is required to go through a 46-hour training to receive the certification. So it's more of the peer services provided to the client, to the individual on site. In addition to that, for this particular program, the client is required to be co-enrolled in an outpatient program. So usually we have our ladies that transition from our PPW program over to RRH who are already enrolled in our Mommies outpatient program. And our Mommies program serves the same population, opioid use disorder for parenting and pregnant women. So they have they're not already, but will be enrolled into our Mommies program once they commence from our PPW program. This particular outpatient service provides group counseling, relapse prevention, parenting curriculums. They also have individual sessions with the counselor. So it's an outpatient program. If the individual chooses not to pursue the Mommies program and chooses to attend a regular outpatient program, that's fine, as long as they are connected to an outpatient program and receiving peer services. And as I mentioned, the peer services are provided on site through our recovery coach. So what the schedule looks like for an individual in our NAS Recovery House program, depending if they have kiddos, we do provide transportation. So they are dropped off at the daycare, or if they have something set up as far as a babysitter so they can attend groups, or that's something that they set up on their own, that's fine. But we do have transportation. They are supposed to engage in outpatient services, recovery groups, and peer services throughout the week. We do have daycare pickup. They are required to contribute to the home. So as far as picking up after themselves, communicating with the staff to ensure that the staff is aware that they'll be heading back to the facility, in time or not in time, they are required to be back to the facility by 8 p.m. So these individuals, once they present on site, they are required to breathalyze, and then they do submit to random UAs throughout the week. We do have a house meeting every night for these particular ladies. They have time before they go to bed to shower, read, have some quiet time, and then we have lights out at 10:30 p.m. So this is more of a living situation, a drug-free living situation, a safe and drug drug-free living situation for these ladies to continue to work on their recovery. This is a step down from an intensive residential program to more of a sober living before they reintegrate into the community. So this is fairly new. We reestablished this program back in the end of March. So we have a couple of ladies who graduated from the PPW program that transitioned over to the RRH program. One of the things I will say for this particular program, we do have to make sure that we, once they're bringing things in, out of respect for the other ladies who are in the in the PPW program, we do make sure that, no food or drinks or, inappropriate items are brought into the house. We do look at, turning in their cell phones as well. We try to monitor that as closely as possible because the other side of the house, the ladies it's a very intensive program and they don't have their cell phones on site. So we do have to watch for, for different items that may surface that may impact or interfere in the other side of the house, but more, but what I've seen in my experience are, the ladies are usually gone throughout the day. They're busy with programming and attending groups. So we haven't seen too much of an impact on the other side of the house, but more so a perspective of looking forward to transition into this particular program once they commence. And we are looking at this program more of a 3-month program. And if the individual is needing to extend, we can look at that case by case. We do have some ladies who are not able to work, who are on SSDI and they're, on a wait list or they need intensive case management. So we do look at the situation and just determine from there. And there'll be another slide providing a little bit more information on the recovery housing program as we get further into the presentation. For the NAWS program goal, we want to provide services in a non-judgmental atmosphere of acceptance that project programs and staff commitment to serve all women regardless of their background or situation. Support the women served and enhance the lives of mothers struggling with addiction by accessing resources in hopes of facilitating a transition into a healthier, more positive lifestyle with sustained abstinence as a primary goal. The program strives to aid each program participant along with their children in establishing and maintaining lifelong stability and self-sufficiency. Provide trauma-informed and gender-specific treatment in the interests of promoting recovery and substance abuse and dependence to a specialized population of women to achieve abstinence and meet recovery goals. We also provide comprehensive case management to assist in achieving stable recovery and preservation of the consumer's family. So for the NAWS PPW program, again, it's a shared facility. So for this particular program, we have identified 11 beds for this program. 3 of those beds are dedicated to women and children. So we do have ladies who come in pregnant and do give birth during their stay. So we dedicate those specific beds for those for women and children. We have 3 of those beds for that purpose. We do have ladies who come in with their children. We have a crib. We have everything set up for breastfeeding, a crib set up. We do provide a schedule for our mommies to make sure that they're able to document, when they're feeding their babies. A lot of times, this is the first time that they have a kid, that they have a baby. They're used to coming out. Most of our ladies come from the streets and they're using, and this is new to them, the abstinence, the sobriety, and then they have the baby and this is their first baby. So we provide that support in that sense as far as keeping them in a structured, a pretty structured schedule. which consists of still attending groups. We do have our parenting groups. They do make sure that they're on a schedule for feeding, and then we do promote time for themselves throughout the day so that they can rest, especially if they're up throughout the night and scheduled to breastfeed overnight. Every 2 to 3 hours. So we do provide that service. So for our NAS PPW program, our staffing looks like our clinical staff. We have an LCDC and an LPC on site. We do have recovery support specialists on site, and these individuals act as direct care staff. So we have 3 different shifts. We have 6 a.m. to 2 p.m., 2 p.m. to 10 p.m., and then overnight from 10 p.m. to 6 a.m. So these ladies provide, the necessities and support to the ladies throughout the day and throughout the night. Our staff does have lived experience in either mental health and substance abuse or both. So they're able to help the individuals through their struggles and talk to them within their scope. We also have, as I mentioned before, the same recovery coach providing services to our RRH program. This individual does provide services to our PPW clients, individuals as well. So what that looks like for the peer services, they meet with, depending on the intensity, if an individual is needing a little bit more of that extra support during their adjustment to the program, we do have our peer who meets with the individuals from a minimum of 1 to 3 times a week, more if needed individually. And they also do conduct peer groups within their realm. So they provide that at least once a week. If we see that the ladies are needing a little bit more support, or there's a certain type of, topic that's circulating around the house that we feel would be a good time for the peer to address that during group, we'll add in or slide in an extra peer group. But as I mentioned, we also have an LCDC who the ladies meet with once a week to provide chemical dependency counseling, and then our LP within their scope. And then we also have an LPC on site who provides trauma-informed counseling. So again, our ladies, this is a 3-month program. So during the referral process, our ladies, again, they must meet the opioid use disorder, moderate or severe. They do not have to be homeless, but if they are, that's okay. And we'll get into the exclusionary criteria a little bit later, but with that, if the ladies are coming in and they do require detox or need to detox prior to our program, we will require them to go through detox first and then transition into our program. We do not want to see any ladies detoxing on site. We don't have the medical staff for that. So we do ask that they go through detox and then come to NAS, so that, and we do have a detox facility within the Center for Healthcare, so we're able to communicate and collaborate for a smooth transition from detox to the NAS program. But going back to our staffing, the clinicians, the LCDCs and LPCs, they do provide groups, 30 hours of groups a week. And that includes not just our clinicians on site, but other outside facilities. We have teamed up with A&M students who provide the nutritional groups. Our clinicians provide life skills, trauma-informed, relapse prevention, parenting, sexual health, and again, nutrition. With that, on top of that, again, the individual sessions once a week. So we also have a case manager on site. We do look at the case manager joining in a little bit later into their programming. The first 30 days is an adjustment period for them, for the ladies coming in. So we don't want to overwhelm them with worrying about getting their ID to get housing. We want the first, at least the first 30 days for the ladies to adjust and really focus on their recovery. And then from there, we'll look at having the case manager then join in after the 30 days and help them with the case management. We do understand that it is a struggle for the ladies for the adjustment, especially with the lifestyle that they've pursued for many years. So I am proud of our staff. Our staff has been able to pivot and shift, to the individuals or the ladies that are on site that are really struggling, whether it's PTSD or, having some mental health issues. They're really focused on helping them through that. So, which is why we have a mixture of different staff on site, from clinical to peer. And then again to our recovery support specialists. We also do have our physician's assistant who is on call for the division. So if we have any, medication questions, or, there's a medical issue that surfaced, since we don't have medical staff on site, we do contact our on-call PA 24 hours a day if needed, if there's, medical question that's really out of our scope. But the ladies do take medication if they're prescribed. We just, especially for those ladies who are on methadone, we do have a medication room or we do have the staff station, and in our staff station, we have the medication locked up, and we do monitor. So when the ladies come to take their medication, our staff, we just monitor, but the ladies administer their own medication. As far as our methadone services, we do have a methadone clinic tied to the Center for Healthcare Services. So we do have our nurse that transports the medication to the facility, and the ladies administer their own medication. A lot of things have changed since COVID, so we try to shift and pivot as much as we can to accommodate the ladies, especially with this intensive programming. And again, I think I mentioned this is a 90-day program. The ladies do receive a certificate at the end of the program, as well as a certificate for the parenting sessions that they do have throughout the program. And we do pull that curriculum from the SAMHSA website, as well as our relapse prevention curriculum we do pull from SAMHSA website. We do use Seeking Safety for trauma-informed. We have other programs within the Center for Healthcare that does provide groups as well, as far as tobacco cessation, our sexual health groups. And we do team up with Corazon Ministries, one of our local partners or resources, community resource, to provide HIV testing on site. We do have an individual who is certified in that particular area and can provide that particular testing there at the program, or we can go to them. So we try to partner up with our community in different areas, and it's worked out pretty well for this particular program. The ladies are very content and happy with the resources that are available to them, and especially if they're willing to travel to on site, they love that. So it's been very great to be able to team up with our community and provide specific services for these ladies. And then again, just recapping, our program serves women 18 years and older that are pregnant and parenting minor children. So the children do have to be under the age of 17. Our core services, and we do also work with our Child Protective Services, the Texas Department of Family and Protective Services. We do get referrals from CPS. And we do take a collaborative and team approach. So our clinicians, our case manager, and our recovery coach, we do team up and collaborate with CPS and different programs that the individuals are assigned to within the Center for Healthcare Services. We do have, referrals coming in from drug court, family court. So we do take a collaborative approach. We usually we'll schedule sessions, depending on where the individual is at, if they're needing extra support, and just to know that we're working together to support them to be successful in their recovery. And, if this individual is working towards family reunification, we do work closely with CPS for that. We can also be a safety plan as well for these ladies. And again, they have to consent to that. So, we walk them through the consents and what this would look like if this is what they're working towards. Our recovery coach does, as a form of support, that will sit in on their court hearings if they need to, just to provide that support, not so much to, to talk or provide information about the client, about the individual, but more so there as a form of support to the individual. A lot of the ladies that we've seen, are traumatized, or something happened, and they're really not comfortable speaking, but just having that presence there gives them a form of safety and comfort. So we do offer that to these ladies. As I mentioned, core services are 30 hours per week to include group, 1 hour of individual session. We do offer family counseling as well. So family counseling focused on addressing substance use disorders and mental health problems. Each participant is assigned a primary individual counselor to conduct personal counseling services with a different counselor will facilitate each group. While a different counselor will facilitate the groups that we offer. And again, we have our LPC and our LCDC on site. As far as our treatment groups, as I mentioned, is conducted by our licensed clinician, but we also team up with the Center for Healthcare Services sister programs. So we have our pregnancy and parenting intervention team and our comprehensive and continuum of care team. These individuals, depending on the program, provide peer services and then intensive case management services. These individuals that are referred to the program are automatically linked to these programs, so that by the end of the treatment and they commence, they're still connected to these programs. So there's follow-up once the client or the individual commences from NAS. They will still be provided those peer services and intensive case management services. So even if an individual chooses to self-exit, these programs are set in place to make sure that they still are provided support and the services that they need after the program. We do try to plan as much as we can and come together as a team for discharge planning prior to discharge. But in the case that an individual self-exits, we have these programs set in place so that the individual has some type of support. And if the individual relapses, these programs will connect to the appropriate support systems or connect to the appropriate resources that they're needing at that time to help them. We also team up with the University of Texas Health Science Center nursing staff, and they come I believe, once every other week to provide group. Very collaborative, a very good group that they provide on site. Depending on what's circulating throughout the unit, they'll provide education on fetal alcohol syndrome, SIDS. They also do nutrition. They do, during COVID, we didn't really understand that when it first occurred. So they provided, safety precautions, how to be safe, what to do. So we have that. We also have that. we also team up with UTHSCSA to provide that service. And again, as I mentioned, the Texas A&M University counseling students do provide groups as well, nutritional groups as well. We do have our leisure groups conducted by our direct care staff, and that's usually after hours, after business hours, when the unit has tapered down a little. They do provide leisure groups, and that consists of arts and crafts, self-care activities on Sundays. We do have one of our recovery support specialists during our second shift. Her niche is self-care, so she does a lot of nail care, facials, different items that just make the ladies feel more relaxed. We do provide herbal tea. We're wanting the ladies to start winding down towards the end of the day, especially if it's such intensive programming. We do also offer, or we do allow once every other week drop-offs. Again, it's a closed facility, so we do lock the doors. We're in an area where we need to make sure that we're watchful for any incidences that may occur within that area. So we do the doors automatically lock. So if someone does need to provide drop-offs, or we have visiting hours, we have it during specific times. So that we can, for the protection of the ladies in the area that we're in. So we do have specific times for families to visit. We do have specific times for drop-offs. So if we're not aware of anybody that is coming on site, we're very cautious of that. So we want to make sure, especially if we have children on the facility, we want to make sure that they're safe. So we do ask any family members that are visiting without outside of those times, just to let us know, just to communicate with us. We have a staff, of course, we serve a gender specific population. So we do have gender specific staff on site to provide these services as well. The PPI and CCC staff meet with mutual clients and discuss services. So these individuals still continue to meet the clients throughout the course of treatment. Weekly case staffings are conducted between prevention and intervention team. As I mentioned, we take a very collaborative approach. So we do have a weekly staffing. We do invite individuals to attend that staffing within the Center for Healthcare Services, so that we can ensure that we're providing the services that the client needs at that time. So if they do have a client they would like to staff, we are more than welcome. They are more than welcome to join. So we do have weekly case staffings every week. As far as programming for the recovery house, and again, this is the 3-bed unit for adults, pregnant women and parenting women 18 years and older. And again, the ladies are linked to an outpatient program, as well as obtaining peer services here on site. So the general house rules must be enforced during their stay to achieve an environment respectful of others, to promote growth, healing, and recovery. Failure to comply with these rules can result in discharge. So we do want to make sure that they are accountable for their recovery. We do meet with them weekly just to check in. The case manager will meet with them weekly just to check in. It's not a part of the service, it's more of the peer services, but we do want to make sure that they do understand what to do and where to go moving forward. If they have the resources that they need, do they still need any case management? And this is more so for ladies who do not wish to pursue our PPI and CCC services. We want to at least have, a check-in and make sure they're on the right track. So engage in intensive outpatient programs such as Mommies, work, volunteer, and then a minimum of 20 hours a week for groups. The recovery support specialists are available on site 24/7. Again, that goes back to the 3 shifts that we have for our direct care staff. Clients engage in weekly individual sessions with the recovery coach to strengthen the foundation of their recovery. We do encourage the ladies to have a sponsor or be connected to a sponsor. We do encourage them to pursue their own pathway to recovery. Not, you know, everybody's doesn't really take to the NA or AA or the 12-step programs. Some, you know, prefer faith-based, others do not. It's just, it just depending on what they're looking at and what they want to pursue. We do encourage them and support them to choose their pathway to recovery. Again, this is a smoke-free facility, so no smoking is allowed on site. We do encourage the ladies who do smoke or who smoke prior to the programs look at nicotine patches or some type of tobacco therapy to help them through the program, whether that's, you know, gum or the patches. So we do refer them to their medical provider. You know, once they get on site, if they are pregnant, they are linked to an OBGYN that follows them throughout the program up until till they graduate, and then thereafter, that continues. So we do provide, we link individuals to that service as well. If they are not pregnant but do need medical care, we do link to our primary care services located at our restoration center for individuals who do not have insurance. So we do try to link these individuals or connect these individuals within the Center for Healthcare on their specific needs, whether that's medical. We'll link to the PCP, to our primary care services, or mental health. We'll link to our mental health outpatient services. And most of our individuals that go through our intake process for mental health services are linked to our Paul Elizondo Clinic located downtown next to Haven for Hope. So we do provide that transportation to and from appointments like that. So the ladies, we try to look at their needs, the areas that are needing to be successful in the recovery, and connect and link these ladies to those specific resources. So our residential operations, we do have, as I mentioned before, experienced compassionate support staff, provide services and counseling in a supportive environment. Initiate drug rehab treatment, detox from all substances, of course. Again, as I mentioned, we send to our detox unit if we need to prior to entrance into the program. Individualized treatment and high quality medical care will connect to, whether if it's the OBGYN or the primary care clinic, we'll connect the ladies there. Again, this is a 14-bed facility. Home-like environment. We do have 2 day rooms, an indoor and outdoor exercise area, and a children's play area and dining facility. So when family come to visit our ladies, we do have a play area outside so that the ladies can spend time with their children if they don't live with them on site. Again, we do welcome children 3 years and younger to the program to reside with mom. If we do have children older than that come to visit mom, we will definitely accommodate with a little play area for kiddos. Again, this is a tobacco-free facility. Nicotine replacement therapy is available. 70% successful completion rate, competitive with a national average. Referral connection to follow-up recovery support services. So again, we do provide referrals to resources that we see the individual needs prior and after. Especially if they're not wanting to focus on their mental health during the program and they want to look at that after they complete the program, we'll definitely refer to mental health services. Trauma-focused therapeutic treatment and education is provided. And then as far as the referral process, just getting a little bit more detailed in this area, clients can be referred through court, as I mentioned, CPS and other services, OSAR, our outreach screening and assessment referral program, and or self. So referrals are submitted into the Columbus system referral forms along with the consent for CHCS prevention and intervention services. So once we can get a referral multiple ways, we could get it via email, they can call the unit directly, they can go through our OSAR or our OSAR program, and they will refer the client to us. Last year, we had an individual who was out of San Antonio calling from a hospital asking for information about this program. You know, we were able to get this individual from that particular place in Texas to San Antonio specifically for the NOS program. As long as the individual resides in Texas, we can look at different avenues to help get these ladies to our program for services, which is why it's super important to connect these ladies to our CHCS prevention and intervention programs. As I mentioned before, our PPI and CCC, this program will follow these ladies prior to ensure that there's continual engagement and connection to our residential program, and again, then after. So if external programs or external referral submitted to, the referrals can be submitted to the linkage department or outreach department, which again is our PPI and CCC program. The program supervisor will screen clients over the phone within 24 hours of receiving a referral. So we'll have 24 hours to ensure that, you know, we get the information. At times, some individuals will drop off, which is why it's super important that we link to these to the PPI and CCC program. They'll continually make engagements with the clients. And get their treatment team involved if they need to, but we want to make sure that we take a proactive approach prior to getting these ladies to the NOS program. The speaker, the supervisor, or if after hours we get a call and direct care staff answers, they understand and know how to do the screening. So whoever answers that phone speaks directly to the client to ensure the client is eligible and qualifies for services and readiness. Again, ladies who are 18 years and older, parenting or pregnant, and self-report diagnosis of opioid use disorder, moderate or severe. Once we do that screening, they indicate they have that diagnosis or have used opiates or opioids, we'll refer to our OSAR department to actually do the substance use disorder screening and the diagnosis to confirm that they have, in fact, that they are diagnosed or will be diagnosed with OUD. If the client is interested, PPI CCC enrollment will occur. So even if they're not interested and they want to pursue this program, they can. And most women, they do enroll in this program, and eventually with engagement, building rapport and trust, they will eventually engage into NOS treatment. Client will be referred to NOS and screened using NOS program referral form. While completing the NOS program referral form, we'll document questions asked and answered on the form, discuss process and program rules and expectations. The participants will be asked to make a plan with family, CPS worker, drug court, probation, or parole officer for the time that they are in treatment, and discuss COVID test requirements in the last 7 days with negative results. Since we have entered the pandemic, we did have to, like I mentioned before, we did have to pivot and shift to ensure that we keep our ladies and children safe on unit. A COVID outbreak on unit is difficult to navigate through, especially with intensive programming. So we try to take as intensive precautions as possible when we're having ladies who are being enrolled into the program. So for the referral process, again, the substance use disorder screening does take place to ensure that the individual is diagnosed with an opioid use disorder. And again, this happens through our OSAR team. So our priority is pregnant IV user, pregnant or IV user. The individual for the referral can complete the OSAR referral and send to Mr. Clyde Keyball, and our NOS referrals at chcsbc.org. So the emails are listed on the screen if you'd like to take that down if you have a client who is interested in our NOS program. Indicate on the referral client is interested in OATS and potential admission to NOS. So our OATS program is our methadone program for ladies who are pregnant or parenting who feel that they want to pursue methadone, the methadone program, then we can indicate that in the referral. We can more than definitely get the individual screened and linked to OATS if they qualify. The individual needs to have the DSM-5 diagnosis, opioid use disorder, moderate or severe. Upon completion of screening, OSAR staff will contact PPI, CCC staff and discuss screenings and referrals. If the client meets criteria and is interested in NOS services, PPI, CCC staff will contact the NOS residential program for availability. So linkage to services, again, these are the different programs we link within the Center for Healthcare Services. Again, our Mommies program is a specialized female intensive outpatient substance abuse treatment program. So this particular program is open to pregnant women and mothers of minor children, including and seeking reunification with children in the Texas Department of Family and Protective Services custody. Trauma-informed and gender-specific treatment targets mothers who are struggling with substance use and mental health disorders. Comprehensive case management assists in achieving stable recovery and preservation of the consumer's family. Mommies program is collaborative partnership between CHCS, University Health System, and the Texas Health and Human Services Commission. So usually our ladies are connected to the Mommies program after they commence from the NOS program, just because we provide the intensive services for group and individuals on site during their stay. We also look at, a couple of weeks into the program, depending on the case, if they need to be linked to mental health services right away, or pursuing the Center for Healthcare intake track, or we can also connect to our co-occurring psychiatric and substance use disorder program within the Center for Healthcare. Now, this provides an adjunct service to clients with co-occurring and psychiatric and substance use disorders. So it's emphasizing integrated treatment where both disorders are considered primary in existing mental health and substance use case management services. So this program usually does help. They build the rapport, they're engaging with the clients, they're not so sure they want to pursue mental health, but they're really really not on track with that as of yet, but they're not sure, but they still want to try it. We'll connect them to COPS-D program. The COPS-D program will then aid the individual in pursuing mental health should they choose to go that route as well. Again, we talked about our comprehensive continuum of care for females, our CCC program, and our pregnant teen parenting intervention program. So these programs are automatically accompany the individual prior to admission and after commencing from the program. We also connect to our San Antonio Job Development Program. So this is a supported employment program designated to assist individuals identified as having OUD in finding gainful employment. Again, there's our opioid addiction treatment methadone program. Our medication assistance treatment services provided to persons addicted to opioids works to foster destigmatization, encourage new clinical treatment strategies, and ensure clients' rights. And again, as we talked about before, we have our primary care clinic, our Diana M. Burns Primary Care Clinic, which is an integrated healthcare approach. The Burns Bank Primary Care Clinic offers primary care services to people receiving psychiatric services, including counseling, therapy, nursing services, case management, and rehabilitative services, including recovery assistance for substance abuse, mental health disorders, and or diagnosed with HIV. So our admission criteria, the individual does have to they do have to have a negative COVID test within 7 days of admission. And again, we want to make sure that we're taking the precautions with COVID. They must be able to perform their ADLs, able to ambulate on their own. The use of crutches and wheelchair is acceptable. The insurance status, we do take individuals who are uninsured or have Medicaid. And then again, must be diagnosed with the opioid use disorder or must meet the DSM-5 criteria for opioid use disorder, moderate or severe, and must have minor children or currently pregnant. Again, for availability, if you want to check for bed availability, the number directly to the NAS program is 261-1572. Again, we have our outreach department, 210-740-3248. And then another route to take would be emailing the NAS program at nasreferrals@chcsbc.org. NAS residential exclusionary criteria, presenting with withdrawal symptoms. Again, we will encourage the individual to go to detox first, unable to perform ADLs, private insurance and VA benefit eligible.
Somebody asked if there was contact information for Diana M. Burns Clinic.
Okay, so for our primary care clinic, we are located at 601 North Frio. I can get that contact information. I don't have the direct number to the primary care clinic offhand, but I will say if you contact 261-1000, that is our Center for Healthcare primary number, and they can route you to the Diana M. Burns Primary Care Clinic. So if you have any, if you want to contact any type of any specific program within the Center for Healthcare Services and not know which route to take, you're more than welcome to contact our central line. Again, that is 210-261-1000.
I typed it in the chat for you.
Perfect. Thank you. Mm-hmm. Are there any other questions?
Not at this time. Oh, okay. That's the end. Okay. Yes. If you have any questions, you can type them in the chat, or please feel free to unmic. We would love to hear from you. That was a lot of great information, and I'm sure y'all are all processing it. So please, let's hear from you.
Hi, this is Felicia with Life Steps. I was trying to get the residential qualifications or eligibility. If you can flip back to that slide, I would really appreciate it. Thank you. That's it. Thanks.
So again, it's having the negative COVID test within 7 days of admission, ability to perform ADLs, able to ambulate on their own. Again, crutches and wheelchairs acceptable. Insurance status, we do take individuals who are uninsured and have Medicaid. And then again, meeting the DSM-5 criteria for opioid use disorder, moderate or severe. And must have minor children under the age of 17 and under, or be currently pregnant. And then again, the number for the directly to the NAS residential program, our outreach department, and NAS referrals. I will say for those of you who are not sure about, the NAS program and, have additional questions after the presentation, you're more than welcome to contact the actual facility or the outreach department. Even if your clients are not really sure that they want to pursue, the outreach department can definitely help with engaging the client. Any other questions?
Can the COVID test be a rapid test?
Yes, it can. And we have worked, right before I transitioned over, we had worked with our restoration center, because they do, the individuals who are referred to the NAS program, they are required to go through a quick medical screening by a provider, and that provider is located at our detox facility. So we worked on getting COVID tests there, and administering the COVID tests at the medical screening. So we have worked on that. I believe we are now at the point to where we're providing the COVID tests at the medical screening. Once they are screened for NAS, they meet criteria, we will schedule with the medical provider to do the medical screening, do the administration of the COVID test. Once everything looks good, we'll go ahead and transport the client over to the NAS residential program.
We have great presentation. Thank you. Great information. Awesome presentation. Thank you.
Thank you.
And the PowerPoint is in the Canvas course. So when you get in there to complete your eval and get your certificate, please look for that. We do have a question here. Is there any relapse statistical data for the ladies who have graduated from this program?
Ooh, that would be, I would have to actually talk to the PPI and CCC program to get that information, because they do follow the individuals after the program. So I do not have that statistical data on hand, but I can work on getting that. If I can get your email, if I can get your email, I can look into that question and email you directly with the statistical data. I'll be more than happy to do that.
DFPS, you can send her a direct message on the chat, and then she could take that if you want to do, if you don't want to share your email with everybody else.
Yes, please.
Oh, she said it's shared here.
Okay.
All right, any more questions before we wrap up? We have about 2 minutes. All right, well, we'll say goodbye. And Tina, we truly appreciate you participating in the NAS Symposium for Neonatal Abstinence Syndrome Month here in June in Texas. All this information is great, and we appreciate you.
Awesome, thank you. I've enjoyed it. You have a great day, everybody, and I appreciate the questions, and looking to engage in the rest of the presentations moving forward. Thank you.
Thank you so much. Bye, everybody.